Bienvenue à tous à ce webinaire sur les défis du dernier kilomètre. Nous attendons encore que nos invités se joignent à nous. Donc, si vous patientez un peu, nous allons commencer le webinaire dans 5 minutes. Bienvenue à tous, je suis Véronique Dupont de la RHSC et nous allons commencer le webinaire dans quelques minutes. Nous attendons juste que nos collègues et que les invités puissent se joindre à nous. Bonjour et bienvenue à ce webinaire sur les défis du dernier kilomètre. Je m'appelle Véronique Dupont et je suis basée à Washington dans les bureaux de RHSC. Ce webinaire est organisé par le forum SECONAF et le groupe de travail sur le plaidoyer et la responsabilité de la RHSC. Juste pour commencer, quelques questions de logistique. Le webinaire est en français, mais pour nos collègues qui sont anglophones, vous avez à votre disposition un service de traduction qui est en anglais. Ma collègue Madison va...
Service. My colleague Madison is going to tell you how to use the interpretation button. So Madison, the floor is yours.
Madison?
Thank you, Veronique. Good morning and good afternoon, everyone. In case you would like to join interpretation, I have included instructions in the chat. All you have to do is click the interpretation button on the bottom of your screen, and you can join the interpretations. Once you've joined, you can mute the original audio if you prefer to hear only French. And when the French speakers are presenting, then you can go back to the original audio. And so if you have any questions, feel free to message myself or Lucian, and we are happy to assist you. Thank you.
Merci. Donc, nous avons alloué environ 15 minutes pour prendre vos questions après les présentations. Donc, merci de taper vos questions, soit en français, soit en anglais, dans le chat, afin que nous puissions les diriger à nos présentateurs. Vous pouvez aussi lever votre main et poser votre question directement au présentateur. On mettra simplement il faudra juste qu'on mette le bouton unmute. Donc, aujourd'hui, nous avons l'honneur d'avoir parmi nous le docteur Michelle Montoun, qui est la directrice centrale de la santé de la reproduction au Congo. Dr Montoun est médecin spécialiste en gynécologie et en obstétrique. Elle enseigne à l'école paramédicale de Lukabu, en République du Congo. Précédemment, elle était la directrice de la santé de l'enfant. Elle a obtenu son diplôme d'État de docteur en médecine et son diplôme d'études spécialisées en gynécologie et en obstétrique de la Faculté des sciences de la santé de l'Université Maria Ngabi à Brazzaville. Aux côtés du docteur Montoun, nous avons aussi M. Lord Divin Nkunku, directeur des programmes de l'Association congolaise pour le bien-être familial, ou AGBEF. Après son master en population et développement, Lord Divin a enseigné en tant que vacataire au département de macroéconomie de l'Université Maria Ngabi de Brazzaville. Il intègre ensuite le Comité international de la Croix-Rouge comme assistant protection et administrateur des données, avant de rejoindre en 2018 l'Association congolaise pour le bien-être familial. Il est co-auteur de l'ouvrage intitulé « Population, santé et développement au Congo », paru aux éditions L'Harmattan. Et plus récemment, Lord Divin a fondé Action communautaire pour la population, l'environnement et le développement, ou ACPED, une association qui œuvre pour la promotion de la dignité humaine et le développement communautaire. Aujourd'hui, Lord Divin et le docteur Michel Montoun partageront les résultats d'un projet mis en œuvre par l'ACBEF en collaboration avec le ministère de la Santé au Congo. Plus précisément, l'ACBEF, qui est le premier bénéficiaire du fonds de petites subventions, ou fonds SECONAF, a mis en œuvre un projet qui a mis en lumière les besoins d'approvisionnement dans 5 départements au Congo-Brazzaville, un pays qui est largement mis à l'écart par les bailleurs de fonds. Nous avons aussi l'honneur d'avoir parmi nous Frank Royman, qui est conseiller technique senior de la chaîne d'approvisionnement et des programmes de santé de la reproduction à A+ Solutions. Entre 2013 et 2017, Frank était membre du comité exécutif de la RHSC. Il a aussi co-dirigé le groupe de travail de FP 2020 sur la dynamique du marché. Avant de rejoindre A+ Solutions en 2014, Frank a occupé divers postes dans le secteur pharmaceutique en France, en Belgique, en Corée du Sud, au Maroc et aux Pays-Bas. Il a aussi tenu le poste de directeur général des services de planification familiale chez Organon et Merck. Frank nous parlera des multiples défis logistiques pour prendre les médicaments essentiels et les produits de santé de la reproduction disponibles au niveau de la prestation de services en République démocratique du Congo. Il discutera des efforts du ministère de la Santé, de A+ Solutions, pour introduire un modèle de distribution Inform Push, informé dans les zones de santé ciblées. Donc, Lord, je vous donne à vous la parole donc, pour nous parler de ce projet de ACBEF.
Merci beaucoup, Véronique. Bonjour à tous. Je voulais dire toute ma reconnaissance pour cette opportunité qui m'est donnée au nom de l'ACBEF de de présenter les résultats de ce projet SECONAF que nous avons mis en œuvre depuis 2020, au cours de l'année 2020 et jusqu'en mars 2021. Le projet que je m'en vais vous présenter est intitulé « Promouvoir l'accès aux produits contraceptifs en période de crise sanitaire due à la pandémie de la COVID-19 ». Diapo. Diapo, s'il vous plaît. Merci. Alors, ma communication se présente comme suit. Nous allons d'abord parler du contexte. Ensuite, nous verrons les objectifs, la stratégie de mise en œuvre du projet, la présentation des principaux résultats et nous parlerons ensuite des leçons apprises et perspectives avant de chuter sur les recommandations. En ce qui concerne le contexte, il s'agit vraiment de vous présenter le contexte du Congo. Les grands chiffres que l'on peut présenter, c'est que l'indice synthétique de fécondité des femmes de 15 à 49 ans est de 4,4. Taux de fécondité est de 111 au niveau des adolescents sur 1000. Et la fécondité précoce se situe à 26%. Le taux de prévalence contraceptive est de 30%. Et nous avons 38% des besoins non satisfaits. Et l'utilisation systématique du condom chez les jeunes Congolais pour les hommes est à 27,6% et les filles seulement à 14%. Le taux de mortalité maternelle demeure élevé à 436 pour 100 000 femmes et le taux d'avortement clandestin à 23%. Au-delà de ça et bien d'autres chiffres, nous constatons de manière générale qu'il y a une rupture de stock généralisée dans les formations sanitaires en dépit de la disponibilité des produits au niveau de la centrale d'achat des médicaments essentiels et des produits de santé. Il y a également un contraste énorme constaté entre les engagements politiques pris par les autorités et les réalités et les réalisations qui sont constatées sur le terrain. C'est pour dire qu'il y a bien des engagements qui sont pris, il y a bien des documents stratégiques qui existent, mais la mise en œuvre, la concrétisation opérationnelle de ces engagements pris est souvent, ne se fait pas souvent dans les conditions souhaitées. Et donc, face à tout cela, ACVF travaille bien sûr pour œuvrer aux côtés de la population, apporter des réponses et des solutions dans le domaine de la contraception, de la santé sexuelle et reproductive de façon générale, mais du planning familial en particulier. Et le fonds SECONAF a donc été pour nous une belle opportunité afin d'élucider les problèmes auxquels sont confrontées les populations qui notamment se trouvent dans des zones très enclavées et des populations qui sont souvent laissées pour compte. Le projet que nous avons mis en œuvre dans le cadre de SECONAF avait pour objectif général d'emmener les autorités sanitaires à garantir la disponibilité des produits contraceptifs dans les structures de santé des départements au départ de la Sangha et de la Lekumo, mais nous avons dû introduire d'autres départements, vous le comprendrez au cours de la présentation. On a dû intégrer le Niari, on a intégré Brazzaville, on a intégré également Pointe-Noire. Des objectifs spécifiques, il y en avait 3. Le premier, c'était de réaliser une étude pour évaluer la disponibilité et la chaîne de distribution des produits contraceptifs en période de crise sanitaire due à la pandémie du COVID-19. Et le second objectif, à partir des résultats que nous devrions obtenir, faire un plaidoyer pour obtenir l'engagement des autorités sanitaires pour maintenir l'approvisionnement en produits contraceptifs. Et enfin, il était également important, connaissant déjà la réalité par rapport aux hypothèses que nous avions et ce que nous connaissions du terrain, avant de mener l'étude, nous savions qu'il devait être nécessaire d'organiser également des sessions de formation dans nos départements de prédilection, notamment la Lekumo et la Sangha. Pour mettre en œuvre ce projet, nous avons dû réfléchir à mettre en place une stratégie. Celle-ci a consisté à associer au maximum nos partenaires dans la mise en œuvre du projet à chaque étape. C'était pour faire que notre voix puisse porter davantage et que le plaidoyer puisse avoir un impact beaucoup plus grand. Donc, ça a été pour nous important d'associer plusieurs partenaires, notamment la Direction générale de la population, qui est la partie étatique. Donc, étant partenaire du gouvernement, il a été important pour nous à chaque étape de les associer pour donner leur appréciation du travail et des documents que nous produisions. Il y a la centrale d'achat des médicaments essentiels et des produits de santé qui est le principal entrepôt par lequel les formations sanitaires acquièrent, en tout cas les départements, les directions départementales de santé acquièrent des produits. Et donc, il était important pour nous de les associer également. Ça a été le cas pour le Conseil national de lutte contre le sida, aussi pour Action de solidarité internationale, qui a une bonne place dans notre pays et qui également aborde ces questions, et également Médecins d'Afrique, Avenir NEPAD et AMESCO. Nous avons, pour contourner les difficultés liées au déplacement interrégion, notamment étant donné que le projet, nous l'avons réuni.
The project was of course hindered because of COVID-19. Even the regions were closed. We couldn't get from one region to another region. So it was very difficult. So we couldn't really go into the fields to gather data. And so that's why we have actually tried to gather the data on the phone. And we got the data on the phone. We called everyone. We also called civilians, people from our partner organizations, but also civilians, to find out what the situation was all like. And sometimes we were able to discuss things on internet. And so that's why we were able to obtain all the data and didn't collect that data late. Now, I think that we especially wanted to find out what was happening in the rural areas. And we wanted to integrate those rural areas in the study so that we would know exactly what was happening with the contraceptive products. Were they getting there? What was happening to the products once they left the warehouses? And so we actually saw that there were differences according to the different regions. Now, what are the main results we've achieved? We had three important goals, and the most important results were, of course, to see what was happening to the contraceptive products, how about the availability, and we've tried to find out how much money was spent in buying and the logistics of the contraceptive products. Now, altogether, I could say that there's 60% of the warehouses who told us that there was just no money spent on logistics, for example. And even in the rural areas, there the percentage was even much higher. The percentage went up to 85% of the warehouses who said that there's no money for logistics at all. Now, even in the health infrastructures, 63% of them don't have any money to spend on logistics, and in the rural areas it was 72%. So that means that this is a huge obstacle. Of course, they need products, but in the warehouses in Brazzaville, for example, we do have warehouses in the capital, but also in the second biggest city. But we have 10 departments in our country. Well, there's just no availability of any warehouse whatsoever. and they don't have any money to go and get the products from the bigger warehouses. And so that's why it is so difficult to obtain the products. And we've also seen that if people get training, the managers, for example, in those warehouses or in the health facilities, even if it's a basic training, then we do see that training is not a real priority. I mean, only less than 50% is actually trained. And most people are trained when they work in the bigger centers, in the bigger cities, but in the rural areas, there is only a small minority who is actually well trained. And so that's why they often just don't know how much product they have to order, when they have to order it, what kind of system they can use. So next to the fact that there is no funding for logistics, there's also not the knowledge they need to really manage well the IT system. Now, I think that in the health facilities, some of the structures do have some means, but those means are very often not IT related. It's still on paper. And I think that even in rural areas, they are still at 50% of working with pen and paper. So it is very difficult to obtain the right information, to order on time, and to have a good ordering system. Now, we wanted to find out what the main obstacles were, and logistics is definitely one of them. So in general, we can say that 50% of the structures did get money from the public sector, and we do see that the state, the departments, but also the health facilities often use the means they have, their own means to go and get the products. They try to obtain the products however they can by their own vehicles very often. So there is no real transport system very often, and they use public transport systems. And I think that we often see that public transport isn't well maintained. Very often personal vehicles aren't well maintained. And so they have to take public transport. I don't know how, if you know how things work in public transport in our countries, but there are a lot of people in there. You can't take a huge amount of boxes with you. So that means that very often the products remain in the warehouses. Now, when you look at the transport in rural areas, well, we often use a motorbike as well, especially in the rural areas. People often use motorbikes, and that's often just because of an individual initiative. Someone has a bike, and that's the reason why they can get products. But so there is no official system. It depends on personal initiatives. And sometimes they can work with ASBAF, CAMEPS, DDS, DG, or people's informal pharmacies. And I think that before we worked with CAMEPS, but now, well, we see that they can only supply 50% what they get. Well, often it's not enough for the need in the field, but they only get 53%, and so they themselves have to go and ask for extra products. They even have to go to the informal pharmacies to see if they still have products or not, especially in rural areas, for example. Well, we see that the most product is found in those informal pharmacies, and very often those rural pharmacies don't have transport means, and so that is a real problem. And so we often see that if we look at the health facilities, there we have the same issues actually. We see that the district warehouses are very difficult to reach, and they get products, of course, but they don't send all the products to the health facilities. The products don't go where they're supposed to go. They get stuck somewhere because of lack of transport. And so that means that even health facilities who work well, they find it very difficult to obtain products. Now, how often do they get products? Well, what have we seen in our study? Well, then we see that in most of the infrastructure at the middle level, I would say, that most of them, when we look at the health facilities, globally speaking, well, they just don't know what the frequency rate is of getting contraceptive products because there is no regularity at all. The staff is not well trained, so they don't know when they have to start ordering, when they have to start organizing transport. So that means that there is no regular setting and that they don't know when they should order things. And then some, of course, have well-trained people. They have the right information, but they don't have the possibilities to renewal their stock. And so they don't know where to go. They don't have the necessary transport means to obtain the product whenever they are in need of it. In Brazzaville, for example, well, there it's still okay. But in the rural areas, for example, what do? Well, they just ask around if there's anyone from the family going to Brazzaville. Could you please take some product with you? That's how they do things. So they don't get it a lot. Now, when we were doing this study, we've asked as well, what was the stock that they had at that point in time? So when we called them, and then we saw that most of them were just out of stock. Especially during COVID-19, it was very difficult, of course. We couldn't travel. So we said, okay, how about 6 months ago? What was your stock level at that point in time? Well, at that point in time, they had some products in stock, but not many. And there is indeed a difference between the urban facilities and the rural ones. Now, second result we've obtained during our study.
Well, we decided indeed to set up an advocacy system, an advocacy plan. And the members of the coalition in the field of reproductive health had an opportunity, to develop this advocacy work together with us. We also had the opportunity to design an advocacy strategy on the basis of the results we did achieve. And then throughout the strategy, we had the opportunity to carry out some advocacy activities with UNFPA. The first objective was the following. It is the organization which was in touch with the relevant authorities, and we told them, well, it is already very good to have the opportunity to get contraceptive products, but if they don't reach the last mile, this might be a problem, because sometimes, you know, we also have problems of products which are out of date, or which do get to the relevant places being completely out of date. That's why we wanted to be in a position to support the Ministry of Health, with a view to see to it that some money would be allocated to logistics and supplying and transfers in the field. But it is something which was not related to the very mandate of UNFPA. But anyway, we decided to get in touch with the Department of Health and Reproduction Health with a view to determine to what extent this type of situation could be settled. For example, we wanted to have different warehouses located in districts far away from Brazzaville, and make it possible for those places to get their supplies a bit more easily without having to go directly to Brazzaville. So we had something like different centers. We met the Ministry of Health. We had an opportunity to be heard indeed by the Parliament, and to share with them our advocacy work. But the presidential elections were organized at the same time, indeed. And we know that it was quite difficult for us to obtain and get appointments with the relevant authorities because of the elections. And the only possibility we had was indeed to organize only 2 advocacy activities. We also get in the field in Sanga and Lekumu, the departments of district which were selected initially for the project. And we decided to provide some relevant training and determine which needs in the field of training might emerge. And therefore, we had an opportunity to determine which expectations did arise from the field, and we were in a position to train people from pharmacies and from health centers, etc. And the people in charge of the districts were trained, and the same did apply to those managers of the warehouses. And I must say that things went quite smoothly. And at the end, we did realize that this type of training was indeed of the utmost importance, because the level of knowledge indeed initially was quite weak. So we wanted to really improve the management of products. And thanks to those training sessions, people were in a position to better understand the situation and were given tools with a view to secure a best or a better management of all that. So what about the takeaway messages? Well, we did realize that the government did benefit from some support at the level of UNFPA, but the budget allocated to the sector was not sufficient with a view to guarantee and secure a delivery or a supply until the very last mile. And we also determined that it was quite difficult for those remote areas to be properly supplied. So the different regional departments at the level of health, etc., and the central warehouse were sometimes faced with difficulties because of the fact that some regions were a bit remote. And because of all that, we could see that the whole system was not working properly. On top of all that, we had to work with community agents who were not trained, indeed, were not experts in the field of health. And it was quite difficult for them to avoid stockouts, for example, and it was quite difficult for them, to secure the supply of the right product, simply because of a lack of knowledge. And sometimes storage, for example, was not the kind of thing they were familiar with. And the information and management system was not fully operational. We had a problem of a structure. For example, the documentation, the relevant documentation was not always available. And when it was available, it was indeed quite difficult for people to manage the situation. So through the training sessions, we had an opportunity, to avoid this type of problem and to see to it that the information would be reported in the right way. Because if it is not the case, it is quite difficult, of course, to adopt efficient and effective strategies with a view to tackle supplying problems. So we put forward a series of recommendations. First of all, we had to strengthen the management and information system through training, for example. And that's what we did in Sangha, but we have more departments, more districts to be covered. And even when a training were organized, not everyone had an opportunity to take part in the training session, simply because they were living in remote areas and had no opportunity at all to attend the training sessions. So I think that we need to see to it that some modern facilities and equipments are made available to those agents with software, apps, etc., which might help them to improve the information system and the management of information. So we also need a warehouse who is not centralized in Brazzaville, but we believe it would be a very good idea to open other warehouses in areas which are a bit more remote from Brazzaville, areas which might find it's difficult to reach Brazzaville. And we should also intensify and better scale up the advocacy work with a view to improve the budget allocated to health and improve the use made of this money. A budget is defined, and Dr. Michel could probably refer to that, but the amounts mentioned are not always relevant or accurate, which means at the end of the day that efficiency is not really to be expected. We also insisted upon another issue, i.e. the fact that sometimes we have people in charge of management, they don't have a good knowledge of the situation, but through a better path, in terms of logistics and replenishment, etc., this would help us indeed to avoid stock outs or problems, and it would secure that products are available on a regular basis. And we also need to rally and mobilize additional resources with a view to support the actions carried out by the civil society within DRC. We have to bear in mind the fact that the civil society is the first to suffer from the consequences of all that. And we also consider that donors have sidelined to a certain extent the civil society. So I think that there is here a possibility to better improve health indicators in DRC. And given that sometimes those elements have not been taken on board, it is quite difficult, of course, to move ahead. And if you have to make it on your own, it is even more difficult, of course. So this project was of the utmost importance as far as we are concerned. And throughout the project, we did realize it was possible to do quite a lot of things, even with a few resources, because the whole project was carried out with less than $50,000. And we did manage, to reach a certain level of expectation. We were in a position to train some staff members, and this led to very positive outcome within the country. And it means that we are ready indeed to get additional fundings, whatever the level, small grants or bigger grants, whatever. But with that money, we could possibly do something great with a view to improve the health of our population. Thank you so much for your attention. Thank you. Well, thank you very much, Lord Divin. Well, I think that we have 20 minutes left for the webinar. I would like to introduce A&AWG Fofana Cissé, who is the chair, the president of SECONAF. She joined us. So, Nene, I don't know whether you want to say a few words and briefly introduce yourself, and then we will give immediately the floor to Frank, if you don't mind. Well, good afternoon. Sorry for joining a bit late. I'm Nene Fofana Cissé. I'm the regional manager of the gender health department, and I'm also the chair of SECONAF, which is involved in reproductive health within Africa. And it is indeed the French-speaking part of the RHSC, as we used to call it. I'd like to thank Mr. Nkungu, who did a very good, brilliant expose, and I would like now to give the floor to Mr. Roigeman, who is a technical advisor at the level of the supply chain in the field of reproductive health and reproductive health programs. So I'm sorry, but I think that the screen, we have some connectivity problem with Mr. Fofana. So he was in charge of different working groups, the FP 2020 working group in particular, which was related to the marketplace issues. And he joined I+ Solutions in 2014 and had different positions, held different positions within the pharmaceutical sector. And he will, of course, refer to the fact that essential medicines and drugs have to be made available up to the very last mile. And he's going to inform us about the efforts deployed by the Health Ministry with a view to deploy the push system, distribution system. Thank you so much, Nene, for this very kind introduction. And I would like to thank the Reproductive Health Coalition for the invitation. So I'm going to refer to the supply chain in terms of family planning and other related products, of course. So the next slide, if you don't mind. Well, yes, indeed. This is the main outline of my presentation. So we have been committed in DRC over the last 7 years, mainly in the eastern part, in the South Kivu part at the beginning. Now we are involved in 9 different provinces for USAID. At the level of the USAID program. And within that particular consortium, we are supporting the health system, and we help them with the management of stocks at the level of the 179 health centers. So if you don't mind, I would like to focus mainly here on the background and the objectives of this push system, informed push system, and then I will refer a bit more to the system as such, refer to the result, and we will tackle then the Q&A session. So DRC, as I said a while ago, is indeed an environment which is quite demanding, by the way. It is not an easy environment. We have some problems from a geographical point of view. We have mountains, rivers, lakes, and so on and so forth, which means that it is not easy at all. And the country is also quite big, as you can see. So here, if you look at the South Kivu region, it does have the same size than Rwanda and Burundi put together. So it is a very big country indeed, with a road and traffic system which is not well developed, and because of the weather situation, it is quite difficult indeed to transfer products from one place to another, from the health areas or the warehouses towards the health centers.
There's no internet in the rural areas. And also when we talk about resources, well, they're rather limited as well. And just as we've seen for Congo-Brazzaville, we see that management tools are very often absent. And so that's why it is very difficult to make the logistics work well. And then transport, well, there isn't enough money in the health facilities to go and get their products in the health warehouses. And then I'm not even talking about training they need about logistics and assisting or supporting the health facilities. Now, of course, they have donors. Donors are ready to help, but without the donors, it would be completely impossible. So the Push Informed campaign was made in 3 campaigns. Youngsters S3 together with Coordate, that was financed by the Dutch Foreign Affairs, and they wanted to increase access for youngsters, also to have the rights of youngsters respected, and they also wanted to work on a holistic care system for victims of sexual violence. And together with those 2 programs, we worked in 12 health zones, in 156 health facilities. Together, we had 302 million inhabitants. Next slide, please. So here you see the system, the logistic system in the RDC. So you have the regional distribution centers. They transport the products up until the health zone level. USAID, for example, we have the technical assistance who make sure that the product is going from the RDC to the health zone, but then it are the health facilities who have to go and get the products at the health zone. So each health facility has to go individually to the health zone to get their products, and that has a huge impact, of course, because transport is quite expensive, because every health facility has to go to the health zone, and it's also difficult to know what is going on, because most of the health facilities, they don't have internet. Everything is written down on paper. So even at the level of the health zone, they can't verify what has been done with the products. And so let's just say that the situation is rather difficult. And so very often they are out of stock. Some have even excessive stock. A lot of products are expired. And very often the transport costs are very high. Next slide. Now, what was our approach? Well, we have only a small team, and that team supported the whole health system. So we weren't there to develop parallel initiatives. No, we really wanted to support the health zones and the health facilities to reinforce their system, to coordinate better, and to really make the bridge between the health zones and the last mile, so that the information is clearer, that it is visible. What stock do we still have? How many products will we need in the near future? And to make sure that there is a regular transport to the health facilities. Now, in the beginning, before we started, we had to get our basics right, of course. So we started making a quick analysis of the supply chain of each health zone. So what is the supply chain? Then we determined what the gaps were. And then we validated a curriculum for training, which we've used, training on the supply chain, taking into account the analysis we had made, working together with the CNAM, the National Infrastructure of Logistics. And the first thing that we've did before starting the training, and Devin also mentioned that, well, we made management tools available, because very often those management tools weren't available. And so the information system can never work if there are no computers, etc. So it's very important to know what's happening, and that's why they needed management tools. And then we started with our training program. So training programs at the level of the health zone. And the goal of that training was not just knowledge transfer, about the supply chain and how to work with the management tools, but we also wanted to come up with an improvement plan for their zone. And that's what we're doing now. We're making up these improvement plans to make sure that after the training, they have a plan for continuous improvement, because continuous improvement of the supply chain is very important, especially in the last mile. Now, it was important work, of course, because now, if you look at the system now, if people don't have management tools, if they don't have IT tools, it's very difficult, of course. So what have we changed in this whole value chain? Well, up until the health zone level, everything is exactly the same, and they still get their products from the regional distribution center. But then we change things around. Instead of the health facilities going individually to the health zone, we said, let's pool the transport means together, and let's make sure that it is the health zone who organize the distribution towards all the health facilities and to make sure that all the products get regularly to all the health facilities. So we made up axis of distribution. There are about 20 health facilities for each health zone. And so we've made it, we made a distribution axis and we also involved the community through making sure that they exchange the data and that they help distributing the products. Now, CODESA was already involved in making an inventory at the end of the month, for example. So we said, okay, let's just enlarge this system. And of course, we also accompanied the introduction of the IPMs. Now, as we've said, we wanted to make sure that there are distribution axes. And so we looked at the distance of each health facility. We looked at what the geographical obstacles were. So we determined the degree of complexity. And we said, okay, what's the most efficient way to transport the product to the health center? There were different axes, and very often they were quite similar. The same axes were recognized in the health services. So what we did do after we evaluated the degree of complexity, then we identified the means of transport used. Sometimes it was a motorbike, very often it was a motorbike or even a jeep. Everything depends on what the geographical situation is like. Then we decide what kind of transport means we were going to use. So we try to optimize the access, the distribution, and because of this system, the health zone became responsible of organizing the distribution and to ensure a delivery plan at district level. Because in the beginning of the month, you will have the push axe. So all the documents, everyone reporting on their stock, etc. We got that information from the health centers to the health zone. And then a couple of days later, we verified, of course, all the documents we've got at the level of the health zone. And we put it into the IT system. And then afterwards, we started to distribute the products they needed. So our focus point were, of course, the members of CODESA. And for each action, we had a focal point, and they have to organize together with the health zone the distribution of the products. So they do have management tools. They report every month towards the health zone. And then they also have to take care of the physical distribution of the products towards the health system. So that was what we call the focal points. And then we've tried to assist, of course, the IPM with technical assistance. We also supported the implementation of those IPMs, and we've also looked at the transport costs and how to organize meetings. So what happened during the year? So you can see it on the next slide. There were actually 2 health zones, donc Katana, that's where we intervened, and then we had the control group. So 1 intervention group, 1 control group, and so you can clearly see that in the intervention group, the availability of the reproductive health products increased enormously. Look at April, May. Then we had a lot of strikes. So the strikes of the health workers. So that's why in May, April, the figures go down.
Par la suite, ça s'est régularisé.
And after that, of course, the situation was settled. So it means that we had 78% on average, which was available in terms of products related to family planning. So next slide. So in terms of stock outs and expiries, we did manage indeed to reduce considerably those figures and those problems, thanks to the focus, thanks to the good monitoring in terms of products. The situation did improve to a large extent. What about the transportation cost? Well, indeed, we did manage to reduce it to a certain extent. First of all, instead of inviting each health centers to go to the health zone with a view to get a product, it was decided that the health zones would deliver the products following some specific routes, and this led to some savings in terms of the transportation cost. And then at the very beginning, we had only family planning products which were impacted by this device or procedure. But later on, it was decided to add other products, other health products, of course, which were added to the initial shipments, if I may say so. And this had a huge impact, of course, on the decrease in terms of transportation cost. So what about reporting and the fact that reportings were made much more swiftly indeed? Well, we can see here a huge improvement of the situation in terms of reporting, this was done much more quickly, thanks to the training session we did organize. And this improvement is also due to the fact that we reshuffled a bit the organization in terms of data transfer and products deliveries. Next slide. Well, in conclusion, thanks to this IPM approach, we had an opportunity to improve the last mile challenge, if I may say. We had more regular reporting from the point of view of logistics and transport. So at the beginning of each month, we had the opportunity to organize this. There was also a better visibility regarding supplying data. And those data were improved to a large extent. We had a better planning approach in terms of distribution. And we also had the opportunity for health areas, health zones to determine how to plan all that. We had the possibility to pull together, to have a kind of pulling effect, if I may say so, in terms of transport up to the last mile and to involve the community at large. Well, and this improved the availability up to the last mile. Thank you. Thank you very much, Frank, for this brilliant presentation. And I believe that we have learned quite a lot about the last mile with this informed push system. And I do believe that you did manage to solve those problems to a great extent, and the percentages did increase quite a lot. We almost reached a level of 100%. So now we are supposed to deal with the different questions. And I think that Mr. Dasidi raised his hand. But before dealing with the questions, I would like to insist upon the fact that both speakers did refer to training. And I did appreciate the fact that it's not only a matter of organizing training of trainers with a view to cover the last mile, but the idea is to improve the availability of products all over the area. And I would like to know which opportunities we do have in the field of training, because distance is a problem. We also have climate issues, etc. And I live in Ivory Coast, by the way. We are faced with exactly the same problems. We have less mountains, but we have to take on board the geography, the mountains, the weather, and so on and so forth. So what are the possibilities regarding training? Yes, indeed, Nene. For the time being, we are busy training 400 people within a DRC, and those people are being trained in the field of supplying chains. Everything is done in the physical premises, so it is not a distant training. And we have indeed a platform which is called I+ Academy, and it is through the e-learning system that we have this possibility to organize, on top of everything, distant learning initiatives. And the objective is to create an academy, the I+ Academy, and we would like to turn this I+ Academy into a platform which would be fully adjusted to the circumstances and the structure. So everything will fit with the supply chain system in DRC. And the objective at the end of the day would be to use the platform to train people nationally, and then to train people at the level of the provinces, and the same does apply to health areas. Because we do have computer, we have the internet, and so on and so forth. And sometimes we need more internet accessibility with a view to deploy this type of training to a greater extent. And I think that the idea we have in mind is to follow that particular path and to get at the end of the day a platform which might secure some distant learning activities. And I think it would be on top of that very interesting to adjust the training to the different levels, so to the level where people are active indeed. Well, it's a very interesting example of scaling up the initiative, and this might be of interest for the other countries. But Diva, what do you think about training? Because you did raise the issue of training at the level of basic education. Do you believe that this might be a solution regarding Congo-Brazzaville? Well, thank you. Thank you very much. Well, I do believe that it is the kind of thing we could possibly organize, although we might be faced with a series of hurdles or problems. Not many health facilities do use the internet. It is true that the internet is everywhere. We have the opportunity to get connected, but the availability of computers within those facilities is not to be taken for granted. Anyway, when we talk about training of students, we might have there a very interesting possibility. So it is important to bear in mind the fact that students have cell phones, computers, and provided there is a structure in place, this might be a very good opportunity for them, because they would be allowed to have access to those sessions and courses. And then I do believe that sometimes we do not have, or they do not have always at their disposal relevant equipment. Well, I would like to give the floor to A&AWG Sidi, and we will come back to you, Frank, immediately after that. But A&AWG Sidi, the floor is yours. Well, thank you very much, Nene. And I would like, by the way, to thank both panelists for the brilliant expose, indeed. And I have a question for you, Frank. Well, good afternoon, Frank, by the way. Well, the very first point I'd like to raise is the following. Keep papers, because we had the example in Senegal. It was covered by a donor, if I'm not mistaken, but when the payments were stopped, well, the system collapsed, you know, and I would like to know who's paying for that, and what might be the thoughts behind a possible sustainability. Frank, before you answer, we are going to listen to a second question instead of three. Yes, but it was a very small question, but I would like to give the floor to other people. So you're going to move out with the second question, and then Frank will answer. The second question I have in mind, and I would like to split it into two, a linkage or the link between the data and consumption. You insisted upon an improvement of the data available, but I don't see why this was improved. Is it because of distribution that you did manage to compile better data, or did you organize a training with a view to improve the data? I don't see really the link between the two. And regarding expiries, you told us that we had a decrease, but I don't see the link between this and the system you did explain. Is it because of reverse logistics or whichever? If you could please shed some light on that, it would help. Thank you very much, Sidi. And we are going to give the floor to Frank, who is going to answer. And John posted a question on the chat. And it is true that there are many discrepancies between the rural and the urban world. And it might be interesting to know whether products are really available. And in terms of control and monitoring, can we consider that the situation is mainly related to the implementation of that project in particular? So I don't know whether you might answer directly the different questions raised, very briefly, if you don't mind. Well, thank you. Thank you. Thank you so much for those questions. What about the issue of sustainability? Well, in terms of sustainability, I would say that what we funded indeed at the level of the pilot project, and after the presentation made to DBS, we decided to enlarge, the system and to cover 12 health areas instead of 1. And during the upscaling part of the project, what we did is indeed the following. First of all, we did reimburse the transport expenses. And at the same time, we did moderate and facilitate meetings with a view to set up and trigger off the IPM system, the IPM approach. That's the first point. What about sustainability now? Well, in terms of sustainability, I must say I'm not really sure whether the 12 provinces are still busy developing the IPM. It is the kind of thing we need to check indeed, but I will come back to you about that if you don't mind, because that's the kind of thing I need to check. And then the link or the linkage between the data on the one hand and IPM on the other hand. Well, indeed, what we experienced is indeed the following. We were in a position to report or to carry out the reporting phase in due time. And in terms of family planning, for example, we could see to it that data was sent on a regular basis at the end of the month, and we were able to return products at the beginning of the month as well. And that's the kind of thing which was not part of the usual practice, I would say. And what we decided to do indeed is to see to it that the health areas would be the owner of their supply chain. So instead of going individually to pick up the orders, they could organize the supply through the health areas and through the pharmacists. And this made it possible for them to have this feeling of ownership regarding the supply chain, and they could structure everything and implement everything. Well, Frank, we have an issue with time, but if I got it right, I think that you decided to focus on the health areas instead of focusing too much on the center, and you did invest quite a lot in terms of data. These are the two key elements which made the difference, if I got it right.
En fait, on parle beaucoup de country ownership. Ça, c'est en fait.
Parle beaucoup. So we talk a lot about country ownership. So the health zones became the real owners of this whole process. And what we wanted to do is that before we stop this project, we want to go for a sustainability project. But then we had COVID. So unfortunately, we weren't able to do that. But that's something which is absolutely necessary to make sure that those projects are sustainable. And I think we need for every project some kind of sustainability check to make sure that we can continue. Now, I also would like to give the floor to Michelle, because she also raised her hand. And if you wanted to ask a question, but you didn't have the time, then don't worry, you can still ask your question in the chat, and then we'll answer your question in writing. Michelle, I give you the floor. Hello. Now, I don't really have a question. I just wanted to add something after Lord Divin's presentation, because can you hear me actually? Yes. So thank you, the UNFP. We see a lot of things which are improved. And so at the end of the year, we make an inventory and we order the products so that we can distribute them in all departments. Michelle, we're very sorry, but your connection is very weak. We don't really understand what you're saying, unfortunately. Michelle, sorry, but could you please write your comment in the chat function, because we can't hear you.
Véronique, peut-être qu'il faut couper son micro.
Véronique, maybe you can just mute her, because we can't really hear what she's saying.
Oui. Écrivez votre commentaire dans le chat parce qu'on ne vous entend pas.
Michelle, please, could you write your question or your comment in the chat, because we can't hear what you're saying. The connection isn't good enough. Sorry. Now, Divin, you talked about the difficulties and the fact that Congo is a country which is not well financed, that there isn't enough financing. But what are the creative solutions that you can offer? Because we know that the civil society is very creative. Now, the UNFP is indeed supporting the distribution of contraceptive products, but the last mile is indeed still very challenging, especially in the rural areas. So that's why we would like to get money either from the ministry, and we know that there are other donors who might be interested in giving us the necessary means to work together with the social society. The World Bank does that very often, for example, so that the funds are being managed by civil society, but that the projects have to stimulate, of course, the general health of the population. So that's why we are very interested in the initiatives of the civil society, and we really want to work on this logistic system to make sure that we can cover that last mile. Thank you very much, Lord Divine. You should think about that, but maybe there are other innovative solutions because what we've seen in Africa and also in many other countries is that the private local sector is getting more and more interesting because money from abroad is becoming very difficult. So what I encourage as well is to look at domestic funding from the state or from the private sector to really create an added value with local funding. Frank, you raised your hand, and then there's still a question from John. I wanted to answer the question of John. Okay, go ahead. About the rural and urban situation. If I understood the question correctly, John, you asked, are you able to do a follow-up of the availability of products at rural and urban level? Is that your question?
Sa question,
no.
Sur le rural et urbain, il se demandait plus au niveau national quelle était la situation.
He wanted to know what the national situation was, but I don't even think we have the time to answer that question.
Les différences, parce qu'on voit qu'avec ton modèle,
but with your model, we do see that there was a good improvement in the areas where you have been working, but we also see an improvement in the other areas. So is that a spillover effect or what happened? Look, in the two regions, we also trained them in the managing of value chains. So we trained both of them, both zones, but in the one zone we worked with IPMs and in the other zones they just were working as they were working before. So let's just say that the improvement that they got was just because of the training, I guess. And I also think that there was a very close follow-up. And of course, there was a lot of willingness as well. Okay, thank you very much, Frank. Now I hope that someone is going to translate for the English speakers. But anyway, I want to apologize for being late. I'm going to give you the floor. Don't worry, I'm going to give you the floor for the last words. But just you can say one more sentence and Frank can say one more sentence. I just would like to thank you. We will answer your questions in writing if they weren't answered during the session, but I think it's clear that we have to do things differently. Lord, thank you very much. What I just wanted to add is that our advocacy is about installing warehouses in other departments, difficult to reach departments, because we have still 10 departments who are very difficult to obtain those products. So if we could get some support to get those local warehouses, to get those local structures in those 10 departments so that everyone can get access to those products, then this would be very welcome. So we hope that our ministry or others could help us out to build such infrastructure, modern infrastructure, so that we can really work well on the logistics. And then finally, I would like to thank all of you that we had the possibility to talk about our project and that we had access to the financial means. It really helped us out a lot. Thank you very much. Thank you as well. And then Frank, I also would like to thank everyone. Now, when I was preparing this webinar and when we had the discussions, I was amazed how much similarities there are between the two countries. And the only thing I can say is that the situation of Congo-Brazzaville, it's not easy at all. There are a lot of difficulties with the supply chain in the different districts, in the different departments. If you look at the means they have, well, it's very difficult to make sure that the products get where they have to be on time. So that's very difficult, that whole logistics in Congo-Brazzaville. And so, yes, I would also reinforce Lord's message. We need organizations to get involved in Congo-Brazzaville to start coordinating things. Okay, thank you very much. Congo, I love Congo, Congo-Brazzaville. So yes, please give more financial means to Congo-Brazzaville. But as I said, think of domestic funding as well. Our countries can't continue to depend on foreign money. I think we have to make aware our own private sector, our own political leaders, that some of the financial means have to come from our own countries. Thank you very much for your time. We will send you the presentations after this webinar, and if questions weren't answered, we'll answer them in writing. Thank you very much. Have a nice day or a nice evening. Bye.